Hello and welcome to the final COPD Wellness podcast for the year. At the end of November, Russell had the opportunity to attend the APSR at the Sydney International Convention Centre. While there, Russell was able to talk to Dr. Peter Barnes. Peter is the Professor of Thoracic Medicine and Head of Respiratory Medicine at the National Heart and Lung Institute and Honorary Consultant Physician at the Royal Brompton Hospital, London. Pete qualified at Cambridge and Oxford universities with first-class honours and was appointed to his present post in 1987. He has published over 1,000 peer-reviewed papers on asthma, COPD and related topics, and has edited over 40 books. He is also amongst the top 50 most highly cited researchers in the world, and has been the most highly cited clinical scientist in the UK and the most highly cited respiratory researcher in the world over the last 20 years. Peter's research is focused on cellular and molecular mechanisms of asthma and COPD, understanding and developing therapies and research into biomarkers for these diseases. He is involved in multidisciplinary translation research, which integrates basic science with clinical studies, thereby providing novel insights into common airway diseases. So sit back and enjoy Russell's chat with Professor Peter Barnes.
Welcome to the show.
Thank you.
Could you give us a bit of a background about your experience and your qualifications in the respiratory world?
Yes, well, I originally trained in general medicine and then specialised in respiratory medicine back in the 1980s. And I've always been involved in doing research in respiratory medicine. So initially I was working on asthma and then more recently switched to COPD, where there's a much greater need for research now, I think. So I'm the head of respiratory medicine at Imperial College in London, and I spend most of my time actually doing research. So we're looking into mechanisms and treatments of COPD, trying to understand how different treatments work and identifying new approaches to therapy for the future, which are greatly needed in COPD.
And when you're talking about treatments in what way are they to treat inflammation, for example?
Well, the most effective treatments at the moment that COPD patients are using are long-acting bronchodilators because they reduce their symptoms and prevent exacerbations. And they are pretty well tolerated, but unfortunately they don't target the underlying disease process. So that means they don't reduce disease progression or mortality. And what we really need is to find drugs that suppress the underlying inflammation. Unfortunately, steroids that are very effective in the inflammation of asthma are not working in most people with COPD. So we need to find alternative anti-inflammatory treatments. And that's proved really difficult to do because some drugs have been tested which do have anti-inflammatory effects in models of COPD, it's like in animal models or in cells in a test tube. But when you come to clinical trials, they either don't work or they have side effects that really mean that patients can't tolerate the treatment over a long time. So unfortunately, we don't really have any good anti-inflammatory treatments in clinical development at the moment because all of them have failed.
When you're talking about inflammation, I read an article not long ago about, and you may have to help me here because I'm not a scientist, the NLRP3 inflammasome.
Yeah.
And is that sort of at the top of the tree and what causes a cascade of effects?
Well, the NLRP inflammasome is a cellular mechanism that gets activated in chronic inflammatory diseases like COPD and asthma. And it's thought to be important for causing the type of neutrophilic inflammation, which is the pattern of inflammation we see in COPD and in some people with severe asthma. So people are quite interested in seeing whether you can inhibit the inflammasome. And recently some new molecules have been discovered that do seem to inhibit it. But these are at a very early stage of development. They've only been used in animals at the moment. And I think at the moment people are looking to see whether they might be suitable for clinical studies. So it will depend on, the toxicity of the drug and how easy it is to deliver it to people. So that's something people are exploring.
And would they, something that would suppress or block that would be a pharmaceutical type intervention?
We're talking about small molecule blockers that you would take either by inhaler or as a tablet form.
Yep. Okay. Now, I've mentioned to you earlier that I've been watching a lot of your YouTube videos, and one thing that come up, and I've heard you talk about it this morning, is steroids and COPD and their use.
Yes.
Are they too widely used, and
Yes.
do we need to change how we prescribe steroids?
Well, they're grossly overused in COPD and at high doses too. And this is probably because in the view of many GPs, COPD seems quite similar to asthma. So they're using particularly combinations of inhaled steroid long-acting beta agonists because these work really well in asthma. In fact, they're the preferred treatment for asthma now. And so they just use the same treatment for COPD in a higher dose. And of course people feel better because they get a bronchodilator, the long-acting beta agonist. And so they think the steroid is working because if you actually analyze the trials, almost all the benefit of inhaled steroid LABA combinations come from the LABA component and not from the steroid component. So people have been using it a lot because they were used to giving this drug for asthma, and a very high proportion of patients in the UK with a diagnosis of COPD are treated with high-dose inhaled steroids. It's something like 90%, whereas if you follow the guidelines, it should be much less than 10%. So there's a huge discrepancy. And I think one of the problems is the pharmaceutical companies are pushing these drugs because they make much more money out of the inhaled steroid LABA combination than the LABA on its own. And so this is heavily promoted by pharmaceutical companies, and GPs are using it. But I think we've always known that inhaled steroids have a rather limited effect in COPD. I mean, you can see some reduction of exacerbations, but no improvement in symptoms or in lung function. So they were used in particular to reduce exacerbations. But then it became obvious from the clinical trials that long-acting bronchodilators, either LABA or LAMA, also reduce exacerbations. And I think now we see several studies showing that if you give a combination of a LABA and a LAMA, that has a much better effect in reducing symptoms, improving lung function, and reducing exacerbations. So it really obviates the need for the inhaled steroid in most people. And for that reason, people have been looking at whether you can withdraw the inhaled steroid, because many patients end up on all three treatments. They have an inhaled steroid LABA combination inhaler plus a LAMA, which is often tiotropium or glycopyrrolate more recently. So they end up on all three drugs. And that's not good because the steroid probably isn't adding anything. And what we now know is that high-dose inhaled steroids are actually detrimental in COPD because they have side effects. So the particular concerns we have are that there's an increased incidence of fractures, of cataracts, of developing type 2 diabetes, which is a common comorbidity in COPD patients, of hypertension, and also infection. So it increases the risk of TB and non-tuberculous mycobacterial diseases, and many studies have shown that it increases the risk of developing pneumonia. So for all of these reasons, patients should probably have inhaled steroids withdrawn. And we now know that that's safe to do. It shouldn't be done suddenly, suddenly stopping the steroid, because people may have adrenal suppression from the systemic absorption of the steroid from the lung. So probably you need to just reduce the dose over about 2 months or so and then take them off completely. And the trials have shown that if you do that, there's no increase in exacerbations.
Okay.
The only exception is that people that have a higher than normal blood eosinophils tend to get more exacerbations, or they get them back again when you take the steroid away. And the blood eosinophil count is a marker of whether they have concomitant asthma.
So that's like asthma, COPD overlay.
That's right, yeah, exactly, yes. So about 10 to 15% of COPD patients have an overlap of asthma and COPD, and these tend to have more reversibility, more exacerbations, and they have increased blood eosinophils, which are easily measured. I mean, this is a test that any GP can do because it's just like a normal blood count, and they can show, you just find out what the eosinophil count is. And if it's above 3%, then these are the ones that probably can benefit by continuing the inhaled steroid.
Okay. So is it going to be slow getting that message across to doctors?
I think so, very slow, because they're so used to giving these treatments. And of course the patients don't recognize these side effects for a long time. And the side effects are side effects of aging and of COPD. So diabetes and cataracts are features of aging, and they occur in COPD. Pneumonia is a feature of COPD. I mean, it's one of the comorbidities. So they don't recognize that the steroid may be making these worse. And because it's combined with a bronchodilator, they think it's helping them. And it is, because the bronchodilator helps them. But I think the time has come to really take most people off inhaled steroids.
Okay. Change of strategy, so to speak.
Yeah.
Now, I myself use nutritional strategies to try and suppress inflammation, and I've had some success with that. Do you think nutrition, firstly, plays a big role in COPD patients? And secondly, if a patient can adopt a diet that is less inflammatory, would that enhance their medication?
Well, I think this is a really interesting question, because epidemiological studies and huge population studies have shown that patients having a poor diet do have increased risk of COPD and poor lung function. And that's been linked to poor intake of antioxidants. So I'm a great believer in antioxidants for COPD, because from our research and a lot of other research, we know that oxidative stress, which of course is what cigarette smoke is giving the lung, is a major factor driving the inflammation in COPD. So counteracting that with antioxidants may be very important, particularly as the natural antioxidant mechanisms in COPD are reduced. So they need to step up their antioxidants. And I think that poor nutrition is one of the reasons why COPD is much more common in poor people than rich people. And I think that does relate to diet. But there are other factors in the diet that may also be important. So vitamin D could be important for protecting against lung infection, although it's been difficult to show that supplementing vitamin D has a major effect. But we know that many patients with COPD have low vitamin D levels, so it makes sense that they should get at least normal levels. But I think more trials are needed for that. Vitamin A is interesting because animal studies showed that vitamin A supplements actually can reverse emphysema, which is pretty remarkable. The trouble is that this is in mice, and it doesn't seem to be true in humans because they have a different type of lung to mice. It's a pity because it would be nice to reverse emphysema.
So is there a mechanism that it works by that can be manipulated?
Yeah, well, the pathways are not very well understood, but they relate to growth factors in the lung that get inhibited in emphysema and stop the lung repairing itself. And the idea is that the vitamin A allows the lung to repair itself again in mice. It may be that you could find other drugs that exploit the same mechanism in humans, but that hasn't been done yet. So it's an interesting area to look at in research.
It is, and it's, as I say, it's really occupied a lot of my time over the last 18 months. And I'm going to talk to you about my last guest on the podcast, and his name is Dr. Steve Finney. He's out of the United States. I don't know whether you've heard from him.
Steve Peters?
Finney.
Finney, okay.
Yeah. So there was a study back in 2003 about how they treated COPD patients with high-fat supplements,
right,
and it improved their pulmonary function. In the interview, Dr. Finney told me that he had actually used these supplements to help get patients off respirators because it reduced the respiratory quotient. Have you had any experience with that?
No, I haven't, and I'm not sure. I mean, there was a lot of interest in fish oil as a supplement, as an anti-inflammatory effect, because it was making lipid mediators that were less likely to cause inflammation. And they did trials in asthma and showed some trials were positive and some were not. But I'm not sure if that's been done in COPD, but I'm not really aware of Highfat as a strategy, and don't really understand the rationale for that scientifically.
I think thinking back to the study, it worked on an inflammation pathway, but it is also to do with fat requiring or producing less carbon dioxide as compared to carbohydrates and protein. As I say, it was just interesting when he came up with that because I hadn't had much experience with it either.
Yes, but I think dietary supplements are quite an interesting approach because patients are much more accepting of changing their diet than of taking drugs that they worry about side effects.
And I think you see a lot of many COPD patients being overweight, which is also another burden on their lungs.
Yeah, absolutely. Obesity is very common in COPD now, which didn't used to be the case. I mean, the typical COPD patient used to be cachectic and had a lot of muscle wasting, but now it's much more common to see obese people. And I think that does have a detrimental effect on the lung, especially if it's morbid obesity. I mean, being slightly overweight seems to be quite protective in a way.
But the more you carry, the more you have to work. I think we all have to put up with that.
Mechanical stress, exactly.
It is. Moving back to medications, what do you see the future of medications? What direction do you see them going in?
Well, I think what is going to happen is that you're going to see triple inhalers widely used because they're easy. And I have a lot of concerns about that because for the reasons we discussed earlier, most people with COPD don't need a steroid, and most people with asthma actually don't need an anticholinergic, a LAMA. So I think what's going to happen is that these triple inhalers are going to be really pushed in general practice, and they're going to say it doesn't matter whether it's asthma or COPD, you just give them all the same inhaler. And I don't agree with that approach because I think it's leading to misuse of drugs people don't need. So that's definitely going to happen in the future. What we need, as I discussed at the beginning, is new anti-inflammatory or disease-modifying treatments. And that's much more difficult. I mean, the area that I'm working on mainly now in research is accelerated aging of the lung with COPD, which we now believe to be the main mechanism of the disease. and actually leads to the inflammation. So it used to be thought inflammation causes the aging, but we think it's the other way around. And actually this explains a lot of the complexity of COPD, because you see the same aging process in diseases that are commonly found in COPD patients, like chronic heart failure, ischemic heart disease, type 2 diabetes, chronic renal failure. And these are also diseases of accelerated aging, and so there are common pathways. So what we're doing is working out the molecular pathways of this accelerated aging. And there are drugs that already exist that may be able to stop these pathways and stop the acceleration. So what you want to do is get people back to healthy aging. You're not going to stop aging, but you don't want people to have all these chronic diseases. And this problem of multimorbidity is a major problem for society, because it's going to be the main burden on medical resources over the next few decades. And people over the age of 60 often have 2 or more diseases, and the longer they live, the more diseases they accumulate. And what is emerging is that these diseases have a common mechanism. It's really interesting that you could actually have in the future one treatment that deals with all of these diseases.
Would that be because most of the diseases are inflammatory diseases?
Well, they are inflammatory, but they're inflammatory because the aging causes inflammation.
So it's the aging that causes the inflammation, not the inflammation causing the aging.
Well, that's what we think.
Yeah, well, it would make sense, wouldn't it?
So that's a better way to target the disease, to target the aging process rather than the inflammation.
So we can live forever.
Well, no, you won't live forever, but you'll live healthily
For as long as possible.
for a long time. That's the aim.
Okay, well, we're getting to the end. One question I like to ask all my guests. If you were diagnosed with severe COPD tomorrow, what's 3 strategies you would use to improve your quality of life?
Well, I think a very important strategy is to increase physical activity as much as possible, because we know that reduced physical activity has a detrimental effect, and it's a spiral downwards. So you become less active, and then your lungs get worse, so you become even less active. And certainly in early stages of disease, increasing physical activity is absolutely critical, and is more effective than any drug that we currently have. So that's number 1. Number 2 is to take the treatment prescribed. It's shocking that so few patients with COPD prescribed effective treatment never use it. And if a recent study looking at adherence to inhaler medication in COPD with the sort of treatments we've been talking about showed that only about 20% of patients actually take them as directed. Now, this is shocking. So
it is. You wouldn't think.
No, but it's human behaviour. So I think you should take the treatment prescribed. And the third thing I think is what you were talking about is a healthy diet, in particular eating a lot of fruit and vegetables that give you antioxidants that you're lacking that make the disease worse. So those would be the 3 strategies I would adopt.
Well, I'm sure our audience can get a lot out of that. Peter, I want to thank you very much for your time today. We're coming to you live from a conference, so it's a bit noisy in the background, but I appreciate your time.
Right, thank you, Russell.
Thanks for listening to Russell's chat with Dr. Peter Barnes. COPD Wellness will be back in 2018 with more interviews with professionals, doctors, and patients from all over the world. Be sure to check out the COPD Athlete website at copdathlete.com. You can also find COPD Athlete on Facebook. Thanks for listening.
Bye for now.